to test, then it sort of disrupts the cascade that leads up to testing with CD4. That's the way we look at it. So for us, we're trying to plug in and ensure that it is part of the care continuum. We're also trying to ensure that other models, so in integrated management of childhood illnesses, diarrhea, malaria, where they exist, also plug in, and that inpatient care is really strong when it comes to managing advanced HIV disease. Another thing we're learning is that you need diagnosis. That is the first step, and that is where we tend to miss in African countries, where we screen or we can't screen and appropriately diagnose, and then intervention is delayed. That's another thing we're learning, and that's an area that we really want to strengthen across the countries. And then another area also is that we need to also link communities and facilities. Sorry, I think I can't really see what I wrote there, but I think it's around practical tools, and that's what Jason is going to speak to, about designing tools that can be used, and not just tools for the sake of it. So, I mean, we print out things, but is that really what we need? How do we communicate to the right people? Are we communicating to the right people? That's what we want to share with you today, and that's what we also want to be able to share at the end of this project. I'm going to now hand over and introduce our speakers. And the first speaker that's going to come is our donor, United. We're really grateful to United for supporting this project. They've been immensely supportive, especially with the disruption in funding. And it's been great to see how they have allowed us to be flexible in adapting service delivery and adapting our solutions. I'm going to hand over now to Jess to give the first remarks.
Thank you. So thanks, Remy, and thanks to you all for being here at the end of a long week. I think everyone is getting tired, and I'm really happy to see there's still some energy left for continued discussions on advanced HIV. There's been several sessions over the week, and I hope that we're really managing to get some of those messages out there. We know that in 2023, the UNAIDS data showed there were still 630,000 people who died of HIV, and almost half were in the sub-Saharan African region. 1 in 3 people who come and present to care already have advanced HIV. So the work is not done. I think the work of the Aurum Institute and the partners is very important. And so that's why we're happy as United to continue funding such work. And this comes as part of a portfolio that builds on many years of work. And this particular portfolio supports Aurum. And we have a sort of a parallel project with CHI. And those two together, they cover 9 countries in sub-Saharan Africa. And then we have also a project with PAHO covering 11 countries in LATAM. And so these 3 together make a really important investment for us, because we can use all of the information and the data that they're bringing together, and to look at all the countries and the people that they need to be able to better serve, and to bring that together to ensure better market shaping, that we can use all of those countries together to convince companies to register, to bring products into countries, into guidelines, and finally into clinics and for people. I won't go into too much detail of the work that is included in those, but there's plenty of bits and pieces about research, about diseases that we don't have enough information on that affect people living with HIV, histoplasmosis, severe bacterial infections, and then once we know more about them, what do we do to treat them, and how do we work together to get those drugs into countries? And of course, that goes hand in hand in co-creation with countries. We don't want to set up new systems and new projects that can't be adopted later by the countries. And so the point is really to align with strategies of the countries, the ministries, and what they need to see. And last but certainly not least is the work that's being done with communities. And so Remy already highlighted many of the different partners. They're working directly with communities. We know that with CHI and Africa, they have mini grants that are also going to community-based organizations. And we see, as Remy alluded to, we see this as a really difficult time in terms of funding. And so communities really need to be supported, and we need to make sure that we don't lose all the work that's been done over all these years because of the recent cuts. I'm really excited to see the panel that we have today. I'm also particularly excited to hear about the work on Mpox. That was actually quite an interesting piece that we sort of watched for a while from a distance, and we knew that in Sierra Leone and DRC that Mpox was becoming more and more of a problem. And so as soon as we could see a potential diagnostic test in the pipeline, then we went to Remy's team and to our colleagues who are working in DRC to see how we could bring that together. And so I'm really interested to hear how that's all coming along. So I really would just want to say thank you for all being here on the last day. Pour les amis francophones, je vous souhaite une bienvenue aussi. J'ai un grand plaisir de voir qu'on a le ministère de RDC et puis on a beaucoup de collègues francophones dans l'audience. Donc merci d'être là, and thanks for our partners to continue the work. Shall I hand over to you or to Jason? Go for it.
Okay, thank you. So we're going, and I'm going to hand over to our first speaker, Jason. Oops. Okay.
It's okay, we'll find ourselves.
All right. Okay.
Thank you, Aimé. Okay, let me steal that from you. And if the team could find the source for that, that would be great. Thanks again for coming through this morning. My name is Jason Coetzee from Matchboxology. I'm not going to spend too much time talking about who we are, but I want to talk about why we're here. Part of the focus of the Impact for HIV program has been pediatric advanced HIV as well, and we know that children face unique HIV vulnerabilities. Treatment interruptions are common. I'm going to talk a little bit shortly about why that is the case and how caregivers are in such a unique position to make a difference. And then, as Jess just mentioned as well, early death from undiagnosed or untreated AHD remains unacceptably high. Children experience HIV differently, both emotionally and socially. The current guidelines that are out there are not bad on speaking to children, but often those guidelines end at an English national level that does not address children in rural communities, children in urban communities that are speaking not only different languages, but have a context that is so different, it needs specific materials and tools. Families need simple, stigma-free guidance. This is something that I think is obvious, but still is lacking after decades. And of course, supporting children helps break the cycle of HIV vulnerability. Okay. Under the Impact for HIV project, Matchboxology spent time in South Africa, in DRC, in Nigeria, and we kept hearing the same barriers with respect to AHD. People only present late when symptoms are severe. Caregivers, like grandmothers, lack clear guidance on what to look for. Facility-community linkage is fragile and inconsistent, and often depends on individuals who if they're not there, that linkage just doesn't happen. CHWs are doing heroic work, but they're stretched far beyond capacity. And of course, stigma and fear continue to shape how people understand advanced HIV. The AHD screening pathway is often confusing in practice as well. Understanding these barriers from the inside, from real lives, is why human-centered design became central to the project, and why Remy brought us on board to assist. Human-centered design puts human beings at the center of all challenges and opportunities. What we're looking for is to co-create solutions with those communities that are not only feasible, things that we can do with current resources, that are viable, in other words, they're sustainable over a period of time, but also that they are desirable. Okay, and that is a key element for us. We need to know that we're solving the right problems. Do we actually understand what the issue is at hand? And are we designing the right solutions? What often happens is that projects are developed and designed by identifying the need in the community, okay? And then they look at the viability and feasibility of getting the project going, getting it started. HCD identifies desirability as well. No matter how good a solution is that you put in front of people, if you are not touching their desires, a need to be heard, a need for clear information that uplifts and empowers them, they are not going to use the tool. It needs to be desirable as well. We can skip that one. So the impact for HIV HCD steps, which are still going on, are evidence that is looking at what extant DISC research there is. Empathy, spending time in communities, talking to people, talking to health facility staff, not only nurses, but also those at reception, speaking to caregivers, etc. Then the Eureka workshops. These are the co-creation workshops where we bring young people, adolescents, caregivers, health facility staff, Ministry of Health folks, donor folks, and technical experts into the same room. And they work together, and it works. It's fantastic. This picture is from DRC, and this is a support group linked to a local clinic there. Really amazing, amazing stuff that they do. The next step is execution. That's developing the prototypes from the workshops into testable projects, testable prototypes, and then those are rolled out and evolve continuously as well. Some immersion insights. Apologies. Some immersion insights that we gain from spending time in communities. Disclosure is the emotional fault line. Disclosure is a tipping point, it's not a milestone, and it's a continuous process as well. Parents fear emotional backlash and stigma more than the virus. This is what we heard. And we found children living with half-truths and confusion. Okay, so that element of disclosure is really important. The next is that caregivers are the hidden leverage point. If the caregiver is in denial, the child will not benefit. But most caregivers are under-resourced, unsupported, and overwhelmed. If we empower them, we empower the children as well. Even if the system is technically comprehensive, and in some countries like South Africa it can be emotionally inadequate. The practice can lack humanity, and we're not only blaming under-resourced and overworked healthcare workers, we're recognizing that they are part of a system that doesn't really take care of the human as a whole. But if we give them interpersonal skills, it improves patient outcomes and outcomes in their own job flow as well. Clinic flow, stigma, visibility, and poor environment worsen outcomes. That I think is pretty obvious. And then the emotional burden is falling through the cracks. We need to equip people to deal with the emotional burden. It just improves patient outcomes. Peer group and support changes everything. Team clubs and peer mentors are saving lives, and they really, really are. The more support we can give them, the better. And I need to talk to someone like me. This is super important. I see that Sean, our colleague from PSI, is here as well. There is a project in South Africa called Coach Impilo that is being rolled out into AI. But the idea behind that is that men living with HIV are trained to support other men, not only on imparting information, but also providing life guidance. But you can only do it when you're speaking to somebody like you. And of course, age-based and language-sensitive metaphors build understanding. The disclosure gap is a design opportunity. Okay. We're afraid to disclose, and half disclosures cause more harm than they help. But this is actually an opportunity for us to step in now and provide guidance that is holistic and not just a checklist item, but something that is multi-step and an emotional process. Very quickly in the co-creation workshops, some of the exercises we did were defining success for the project, testing truths, that is validating perceptions versus reality of what we heard in communities, looking at the different archetypes involved, looking at the challenges, putting forward how might we suggestions, and then co-creating solutions. We came up with quite a long list of viable prototypes, and one of the first ones of those that scored highest when we evaluated it was the Community Connected Toolkit. This is the first of the solutions that is being rolled out. And this Community Connected Toolkit is a kit that is designed to be able to give to lay people who are not thinking about HIV every day and part of the industry and the business, or are not necessarily community health workers, but a guide that you can give to a pastor or an imam, a guide that you can give to a caregiver, a grandmother, that gives them basics, but enough information that they are able to make decisions that support good outcomes, either for themselves or for those they're looking after. The shifts we expect to see from this are community members reporting greater confidence speaking about advanced HIV, caregivers and others finally having clear guidance to act early. There's been too many instances where there isn't early enough action. And that communities have a shared and stigma-free language for talking about AHD, and this is key. We need to turn this guide into local languages, and that is in process at the moment. And that is the final point, that tools need to be ready for localization and integration into national guidance. Thank you. That is a brief dip into the human-centered design activities under impact for HIV. Thanks for your attention. Thank you for being here this early, and I'm going to hand back to Remy.
Thanks so much, Jason, for sharing to share her experience from the field. So handing over, I'm going to be a bit stricter on time now because I know that we're running out, but you have the floor.
Good morning, everyone. Like Remy said, I'm Rose from South Africa.
I don't have your presentation online. Okay. I need to look. It's on the big screen here as well.
What I'll be presenting today is the real experiences from the ground, from the communities themselves. So we are implementing output 4 of the Impact for HIV project from Unit 8 through Aurum. And this is around clinic-community collaboration. It's actually part of the bi-directional approach, where we get cases from the clinic that we need to take back to the community, and vice versa, where we go to the community and get cases of AHD and back to the facility. But most importantly, this is the model which is aligned to what South Africa is implementing. As you may know, that South Africa is implementing what we call the primary healthcare approach, which is part of the district health system implementation, where we've got clinics, we've got communities, hospitals, and this model that we're implementing is fitting very well. As I continue the presentation, you'll realize that it's important that we've got an integrated approach in terms of what we are doing in facilities. And what are the lessons that we've picked in terms of the responsive models in practice? There are about 6 themes. I need to come closer because I can't see very well. We have, maybe let me take it from my phone because, yeah. Sorry, can I pass? The first one is around shared ownership of health outcomes. Part of the outcomes that we see in facilities can not only be accounted to by the Department of Health, but we've seen that we need community health workers to improve the health outcomes. Let me give a typical example. Some of the data that we've seen in facilities where children are not suppressing as part of the T95, the third 95, if you don't have community-based organizations to support households, then you're going to suffer the consequences. But if the outcomes in the facilities improves, it's also part of what the work that we've done in the communities. But most importantly, I've said, we also have got a bi-directional way of making sure that the clinics support the communities and we also support the facilities. Remy spoke about the cohesion around integrated service delivery. In the facilities that we're implementing in, some of them have got a dedicated approach where they have dedicated nurses that treat children. But in the absence of those nurses, sometimes in some facilities, children just go unnoticed. We've seen that capacity building is a critical factor for community health workers. In the next slide, we'll see that in the baseline that we conducted, community knowledge is the biggest gap which we needed to address, and I'm happy that Jason spoke about the toolkit that is now being developed and actually being launched here. We also have seen that responsive monitoring and accountability as part of the CLM. That's what we are doing in communities, but most importantly, the issue of sustainability. Okay, we did a baseline assessment around Feb up to the end of May. We had about 95 respondents across 3 districts, and the main objectives, we had about 4 objectives that we wanted to address. What was the confidence levels from the community health workers in identifying children with advanced HIV disease, and whether they were also aware in terms of what to do when they pick those children. We also had wanted to look at community health worker support, what systems exist to support community health workers, but most importantly, what systems exist for community health workers to support children, but lastly, caregiver support and families. And the key findings summarized, there's definitely an issue of knowledge gaps. In the conference, you may have seen that whilst guidelines are coming out for healthcare workers, we have a challenge in communities. And Jason did emphasize the fact that also the language that is being used for training community health workers. There is no IEC material currently in South Africa for advanced HIV disease, but also that is attributed to the fact that the guidelines are not yet out from South Africa. Stigma is very much alive. And disclosure. And what we have seen with disclosure is that disclosure is a make or break point. Where disclosure is done well, we've seen success rates that are very good, but where it's not done or inappropriately done, we've seen that it has got long-term mental health effects. And what have we done so far? We've done a lot of stakeholder engagement at different levels in South Africa. We've also seen that we've implemented the 3C model that I've spoken to, sensitization in communities. We've been holding dialogues and we're getting a lot of insights from the dialogues that we've held in terms of the bottom-up approach. We've formed support groups in the facilities, about 10 facilities that we are supporting, and we've commenced with training. Like I said, we are addressing some of the gaps that we've identified in the baseline assessment. We've also seen that through support from Matchbox, we've inculcated the human-centered part, and as I've said, we've also continued monitoring and evaluation. And just this is part of the case study. This case study in summary is a child who was not suppressing, but also had a CD4 below 200, a typical case of AHD. This child was also disengaged into care. Through the clinic community collaboration, we brought this child back to the facility. And because the child was already presenting with some opportunistic infection, already was showing signs of TB and cryptococcal meningitis, the child was referred to hospital. We continued to support the child in hospital until the child was discharged. But importantly, we've got a lot of psychosocial issues that we had to deal with. Engaged with social development, engaged with education, and the child is now suppressing, as well as now the child is out of danger. And this is part of saving the children with advanced HIV disease. Lastly, this is actually a video, but in the interest of time, it will not be shown. In this story is a sad story of disclosure that went wrong. A young woman who actually is head in the household. Both parents died of HIV, and because they did not get proper disclosure from both parents, they had it from the third party. They suffered long-term consequences of mental health. They are very much suicidal. They had depression. One of the brothers was admitted in a psychiatric hospital, and they also had vulnerabilities where they were also exposed to rape at some point. The young boy was molested. So it's a whole family crisis. But I think in a nutshell and in summary, the community experiences are real, and we want to urge funders, we want to urge participants that community investment in advanced HIV disease program is very critical. Thank you.
Thank you so much, Marose. She emphasized the clinic collaboration model, which is something we also want to share in terms of how we're engaging and trying to close the gap between healthcare workers, the health system, and communities. If we have time, we will play the video at the end. But right now, I'm going to introduce Stéphane. Stéphane works with Solthis and is one of our implementing partners to share. You've heard from the community side, so you're going to hear now from the health system perspective.
Thank you, Rami. Hello. Hello. I know it's a little cold, but we are coming towards the end, so just bear with us a little more. So like Remy said, I'm Stéphane, and I'm going to be talking about expanding access through clinic workflow adaptations. When we talk about clinic workflow adaptations, what do we think about? It's going into the health facilities at all levels and seeing what is being done, looking at how it's being done, who is doing what, and why is it being done that way. And when we understand why it's being done that way, then we can make suggestions to improve access to these services. So, when United just said to Remy, let's do something about AHD, and with Remy came to Solthis and told me, let's do something about AHD. Solthis also went to the National HIV program and said, Aurum told us, United said, we should do something about AHD. And so with the national program, who were happy to receive us, they said, okay, what can we do about AHD? Let's go in and ask these questions: the who, the where, the how, the why. But in asking the why, we understand that the clinic workflows are affected by many different factors. One, do we have the personnel? What's the structure of the facility? At what level of the health pyramid is it? What are the policies in place? What are national guidelines? And so we had these interactions with various stakeholders, the community groups, clinicians, nurses, the National HIV Program, and the Ministry of Health. And in asking this why, we got out a few points. The health systems were fragmented. There wasn't enough focus on AHD in national strategic plans, and the technical guidelines were not as updated as we would like them to be. What this meant was the standard training for healthcare workers was not as up to date as we would like it to be, meaning we had inconsistent practices across levels and across different services. And with these inconsistent practices, meant the standard varied from place to place. We also had a very centralized model of care with limited AHD services and HIV services at primary healthcare facilities, most of them centered around the secondary and tertiary facilities. And what did this lead to? We missed cases of HIV and AHD. A lot of clients were lost to follow up when we had to refer them to services, and because of these broken, fragmented health systems, it also put a strain on healthcare workers. In these central facilities, the hubs, we noticed when all these referrals were done, there was a large queue, and so the healthcare workers were overburdened. In the facilities at lower levels, the referral between departments and between health facilities and back also made it difficult for them to provide adequate services to patients and clients. We also saw that without this focus on advanced AHD, the reporting on AHD indicators was subpar, wasn't as good as we wanted to be, which meant we did not properly understand the burden of the disease and couldn't properly lead our interventions. Looking at all of this, what did we need to do to modify these clinic flows and make them better for patients? Above site here, we worked with the National HIV Program to update the policies, guidelines, and the technical documents. We also updated training manuals and national indicators. One thing we are very proud of in working with the National HIV Program was decentralization of services. We made it such that many of these the services in the AHD package were available at the lowest levels of care. As we can see there, we've highlighted, it's a little bit too small for you to see. We've highlighted the TB LAM. TB testing was only done at hubs and central facilities, but TB LAM is now being done at the lowest levels. We are also able to do CD4 testing, rapid testing at the lowest levels of care. That is work which is in progress and is expected to start roll out in January. Focusing on this decentralization, I mentioned before that the central hospitals and hubs were overburdened with high volumes of clients, which put a strain on the workers, strain on patients. Also, the very sick patients who had to travel from the villages and long distances to these central facilities often gave up, and we lost them in between these health facilities. So what we did was, at all levels, in all health facilities, we went in, provided training. Remy talked before about the HIV cascade and AHD being just part of this continuum. We provided training in all these facilities, and while our training focused on AHD, we did have to touch on these other aspects of HIV. This training included the management, screening and identification of AHD, the management of uncomplicated cases, and being able to identify when to refer. We also provided M&E training in order to get data which will help us inform policy, and lab training for things like CD4, TB LAM, and even crack. The TB LAM and CD4, as I said earlier, are being done now at all levels of the health pyramid, while crack is still restricted to these hubs and central facilities, but instead, rather than referring patients to these facilities, we collect blood samples at the primary health facilities, and through the sample transport circuit which is established, the samples are sent to the hubs, analyzed, the results are gotten, and we can inform the patients without having them carry this burden of moving. Another thing, sorry, I'm not able to see. Okay, our trainings included staff from all entry points of the health facilities. So it isn't just an HIV unit or HIV clinic thing, but internal medicine, the outpatient, and even surgery, when we identify, these are focal persons, identify people eligible for HIV testing and people eligible for AHD screening, they do this screening before we continue the process. It makes it such that we miss less and less cases. Certainly, we heard from our community partners before. We work with the community partners. The one in Côte d'Ivoire is RIPLUS, who help us bring these services closer to communities, generate awareness or create awareness, do referrals to where clients can access these services, and do community follow-up post-hospital care. What these actions have done, we're expecting to improve. It's true we are still in the early stages, so we'll be able to have concrete data after proper evaluation later. But early things we are seeing is all these trainings of many staff at health facilities improves healthcare worker capacity in identification and management of AHD. We also see there's decreased wait times at hubs because of fewer referrals and because clients are now able to access the AHD services at whatever health facility is closest to them. Overall, there's less strain on the healthcare workers and the health system. And we also have fewer loss to follow up. What I'd like to emphasize is that in order to encourage appropriation and incorporation in the healthcare facilities and by the healthcare workers, we establish quality improvement teams in these health facilities. And what they do is once a month, they get together with the focal people from every entry point, sit, review the cases, review the workflow, and bring out their needs and can make adjustments on their own and inform us, which we are able to support. What needs to be done now? We'll continue to use the data we are getting for active management, seeing where are the gaps. We are now able to screen for AHD at all levels, but if the screening is less, we need to ask, why are we not screening all those eligible? This means identifying factors which might be supply chain, might be need for further capacity building and such. Also, we continue to get feedback from all these stakeholders. Is it supply chain training? Do we need to review the flow of clients from facility to facility, or do we need to improve our transport circuit? And those are things we all look at and can act in real time. Next, we are using the data we are collecting from this implementation to talk with the national program and see how do we attribute resources to be as efficient as possible. And the idea is, with this data we've gotten, with a model, a successful decentralized model, with clinic workflow adaptations we've implemented, we can use this as a base for scale up throughout the country. Thank you.
PNLS in DRC to share an example of what we're doing with the Mpox and integration with advanced HIV disease. Dr. Aimé?
Good morning. Good morning.
Good morning.
Bonjour à tous. Okay, I will speak in French because I'm from DRC, a francophone country. Nous avons le plaisir de pouvoir partager l'expérience de la République démocratique du Congo sur l'intégration de services VIH et de la syphilis dans la réponse de Mpox. Et comme on peut se rappeler, Mpox a été déclaré urgence de santé publique de portée internationale par l'OMS, mais aussi Africa CDC, qui avait donc, n'est-ce pas, déclaré comme une urgence de santé continentale. Et donc, dans ce contexte-là, nous pourrions aussi nous rappeler que déjà en février 2023, il a été identifié les risques très élevés de pouvoir voir de forme sévère de Mpox chez les personnes vivant avec le VIH. Et c'est en septembre 2023 qu'on a pu détecter, rappelez-vous, de clade 1B, qui assurait donc la transmission sexuelle. C'est donc dans ce contexte-là qu'en République démocratique du Congo, nous avons voulu intégrer donc le service VIH et de la syphilis dans cette réponse que nous apportions au Mpox. Et donc, nous avions dépisté donc, des personnes, des cas suspects de Mpox déjà, pour le VIH et la syphilis. Donc, vous pourriez voir le résultat qui s'affiche. Et on recherchait donc la co-infection Mpox, VIH, syphilis, Mpox. Alors, vous pouvez voir, par rapport à l'âge, beaucoup de cas de co-infection VIH, Mpox, syphilis, Mpox étaient au-delà de 15 ans. Mais regardez aussi, chez les enfants, entre 0 à 4 ans, il n'y avait pratiquement pas, il n'y avait pas de cas de co-infection syphilis, Mpox. Mais entre 5 et 15 ans, il y avait quand même de cas. Et lorsqu'on regarde la distribution par rapport au sexe, donc on trouvait beaucoup de cas Mpox, VIH chez les femmes et beaucoup de cas syphilis, Mpox chez les hommes. Alors, nous avons étudié d'autres paramètres, voilà, notamment la relation par rapport à l'âge, par rapport au sexe, mais aussi par rapport à l'orientation sexuelle et au statut matrimonial. Donc on peut bien voir que, suivant les données, les premières données que nous avons donc collectées, de données de routine, on peut voir clairement qu'il y avait beaucoup de cas de co-infection Mpox-VIH chez les jeunes adultes, mais aussi beaucoup de cas, beaucoup de risques, n'est-ce pas, de la co-infection Mpox-VIH chez le veuf, le célibataire et même chez les divorcés. Et de la part de ces 4 facteurs, les autres facteurs, donc des personnes qui avaient des formes sévères de Mpox présentaient des risques évidents de pouvoir faire donc la co-infection Mpox-VIH, mais aussi les patients tuberculeux. Les patients qui étaient déjà tuberculés présentaient donc beaucoup de risques de pouvoir faire la co-infection avec le Mpox VIH. Et en ce qui concerne le décès, en tout cas, vous pourrez voir des personnes Mpox confirmées qui n'avaient pas la co-infection VIH présentaient moins de cas de décès que chez les personnes qui étaient donc co-infectées Mpox VIH. Alors, nous avons pratiquement eu 10% de co-infection par rapport aux données que nous vous présentons et qui concernent 11 structures dans la ville de Kinshasa. Donc c'est un peu plus de 17 000 cas de personnes. Donc on est arrivé à la co-infection à 10%. 10%, ce qui est assez énorme. Alors dans le processus de mise en œuvre, nous avions commencé avec l'appui de l'OMS, United, Rome et les autres PATA, avec l'appui des autres partenaires. Nous avons donc élaboré les SOP pour pouvoir expliquer comment il faudrait procéder en termes de dépistage notamment. Ensuite, on a formé les prestataires dans les structures sanitaires, dans les 11, où on devrait intégrer cette intervention. Et nous continuons d'ailleurs, à la suite de la publication par l'OMS de directives sur les co-infections Mpox-VIH, nous venons d'élaborer un manuel opérationnel par rapport à cela. Alors, que ce soit dans le centre de traitement Mpox, que ça soit dans la communauté. Donc nous avions une approche bidirectionnelle qui était proposée. Sur des cas suspects ou des cas confirmés Mpox, on devrait systématiquement leur proposer le test VIH et la syphilis. Donc essentiellement le duotest qui était proposé. Et donc si c'était réactif, on devait appliquer, revenir à l'algorithme, à 3 tests, l'algorithme national. Alors, quelque chose de particulier, c'est qu'avec Aurum, un sous-financement unitaire, donc nous prenons en charge de patients VIH dans près de 10 sites dans la ville de Kinshasa, pour des patients qui arrivent, qui sont symptomatiques par rapport au Mpox, ils sont donc référés pour des soins, n'est-ce pas, Mpox. Et il y avait systématiquement la numération, le dosage de CD4. Parce que comme vous le savez, l'OMS indique que en dessous de 200 éléments de CD4, le taux de décès est estimé à 15%. Et en dessous de 100%, n'est-ce pas, de 100 éléments CD4, le taux de létalité est à plus de 25%. Et donc, systématiquement, il faudrait faire la numération des CD4 et nous utilisons le Visitec, donc le test semi-quantitatif. Et lorsque le taux de CD4 était à moins 200, donc nous nous retrouvions pratiquement dans les cas de sida avancé. Et on devait faire l'ensemble, compléter les analyses par l'ensemble de tests qu'il faut faire, tibilam, etc., pour pouvoir, n'est-ce pas, mieux assurer la prise en charge de nos patients. Alors, ça c'est ce que nous proposons comme modèle, sur base des données que nous avons réunies. Donc il faudrait absolument avoir une approche de guichet unique. Ça veut dire au même endroit, au même site, assurer l'offre de services pour Mpox, pour le VIH et la syphilis. Et il faut absolument une détection précoce, notamment du VIH, une détection précoce et de la syphilis, mais aussi, l'OMS vient de le dire, il faut rapidement assurer les traitements antirétroviraux. Et surtout, avec le fondement immunitaire, il faut y aller le plus rapidement possible. Les partenariats, les différents partenaires devaient se mettre ensemble, ceux qui appuient le Mpox, ceux qui appuient la lutte contre le VIH, la syphilis, devraient se concerter pour mutualiser les ressources, notamment les ressources financières, parce qu'on se retrouve dans un contexte où il y a une crise de financement. Alors, la sensibilisation, la communauté a un rôle important à jouer. Je pense que les collègues qui m'ont précédé l'ont dit, l'engagement communautaire, c'est la clé pour réussir la prise en charge de ces patients Mpox et même des patients co-infectés, Mpox VIH, Mpox syphilis. Donc voilà ce que nous pourrions vous dire en quelques mots en termes de cette expérience, et je vous remercie.
Merci. Thank you. Thanks. Before we close. Yes, please. Does he have a microphone, or do I bring this, or okay?
Bonjour à tous, Valentin Keipo de la Côte d'Ivoire. Merci à tous les panélistes et particulièrement merci à la RDC pour ce bel exemple de surveillance épidémiologique avec des services intégrés. Très bien noté. Mon seul élément de clarification, c'est surtout les facteurs associés. J'ai vu le statut matrimonial qui faisait partie d'un élément, d'une variable sur laquelle l'analyse a été portée. Et je voulais bien comprendre, dans le contexte de la RDC, quelle était vraiment, je pourrais dire, quelles sont les conclusions ou même si ce n'est pas des conclusions définitives, mais quelles sont les hypothèses qu'on pourrait émettre autour de cette variable en lien avec le statut matrimonial dans le contexte particulier de cette surveillance. Merci.
Merci. Do we take the questions first and then we hand over another question? That was for you, Dr. Aimé, right? Okay.
Good morning. So my name is Rachel Kakwaba and I am from Ghana here. I don't know whether I came in a bit late, so at a point I realized AHD was running through. Really, I don't know what it is, and so if it could be explained to me and what it takes for one to also get to that stage, I'll be grateful. Thank you.
Okay, thank you. Any other question? All right, I'm going to hand over first to Dr. Aimé, and then I will speak about advanced HIV disease. Thank you. You have a mic. Is it working? No, it's for all of us, but you can take the first. Yeah.
Ok. Donc, merci beaucoup, chers collègues de la Côte d'Ivoire, pour le mot gentil, mais aussi pour la question. Mais quel serait l'intérêt par rapport au statut matrimonial? En fait, nous avons voulu faire parler les données, en fait. Je précise qu'ils sont des données de routine, et nous plaidons d'ailleurs pour l'extension de cette intervention, parce que là, on l'a menée dans 11 structures à Kinshasa, mais vous imaginez, la RDC, elle est assez grande. Nous voulons étendre cette intervention pour voir si nous parviendrons à une même photographie. Mais sinon, l'intérêt, en fait, de ce statut, c'est de pouvoir soupçonner un peu le comportement à risque. Le comportement à risque, et ce que ces premières données nous donnent, c'est que pour la survenue, les risques de pouvoir présenter la co-infection Mpox, VIH, ces risques seraient plus accrus chez les veuves, les célibataires et les divorcés. Alors je ne veux pas aller plus loin avec des commentaires, et essayons de tendre et de voir si cette tendance pourrait se présenter. Donc voilà, chers collègues, ce que je peux dire. Merci.
Merci. Thank you. And then for the question on advanced HIV disease, so AHD is an acronym for advanced HIV disease. And I think the best way to tell you about it, I mean, in short terms, you would say it's AIDS, right? Because after HIV, you progress to severe illness, and then you fall into the syndrome where there is a lot of other opportunistic infections that affect the person. Now, while the investments were going on HIV, and a lot of the consultations and a lot of community interactions started and were advanced, there was a push to change the language from AIDS to advanced HIV disease, mainly because AIDS was just associated with death. It was just a final. And so if you look at it technically, advanced HIV disease would include people that have stage 3 or stage 4 clinically. So they still are sick, but also if they receive treatment, if they are tested early and they identify that their CD4 cells are lower than 200 cells, they can still receive treatment for any other opportunistic infection such as TB, cryptococcal meningitis, or any other one that actually comes or is associated with HIV. But, I mean, for advocacy reasons, we like to use the term AIDS. A lot of people still use the same term, AIDS, advanced HIV disease. But what we like to say is that with advanced HIV disease, there's a window by which you can still capture and support before it falls into the end stage, which is the AIDS stage. So see advanced HIV disease as more inclusive of the broader, stage 3 and stage 4 condition. Does that work for you in terms of the definition? And apologies for assuming that everybody understands AHD. We were just speaking to the audience as if, right? But it's advanced HIV disease, and it's really that stage that includes AIDS, as well as the stage right before it goes to that final stage. Are we okay? Yes? No? Okay. Okay. Okay, thank you, and thanks so much for attending. Thanks so much to Secretariat for giving us 10 minutes in addition. We appreciate your attendance, and thanks a lot. I hope that you enjoy your travel back. Yeah.